Welcome everyone to the latest What's New in Addiction Social Work Talk. My name is Jessica Mensinger and I'm one of the co-directors for the Addiction Social Work Fellowship Program with the BC Centre on Substance Use. I'm here with my colleague and co-director, Zan Rothenberger. Zan and I are here to host today's lecture and facilitate discussion at the end. So we do encourage you to put any questions you have throughout the presentation in the chat box. Zan will be monitoring the chat today and will field as many questions as we can following Kara's talk. So with that, I am honored to have the opportunity to introduce today's presenter. Kara Schultz is currently a part of the Addiction Social Work Fellowship Program. She has a strong interest and passion for harm reduction and drug policy reform, which has only deepened during her time as a fellow with the BC Centre on Substance Use. Prior to beginning the fellowship, Kara was working as a community mental health clinician at Strathcona Mental Health Clinic in the downtown east side. She's been working in the neighborhood for about 4 years since graduating with her master's in social work from UBC in 2018, and was previously employed as a housing relocation officer with the City of Vancouver. So with that, I welcome Kara to present on barriers in accessing detox, treatment, and harm reduction services. Thank you, Kara.
Thank you for that introduction. And yeah, today's topic will be barriers. So before I begin, I want to start off with a land acknowledgement and respectfully acknowledge that the land on which I live as a white settler is the stolen, unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I also recognize that the ongoing war on drugs, otherwise known as the War on People, including the criminalization, institutionalization, and discrimination against people who use drugs, disproportionately harm Indigenous peoples, and that continuous efforts are needed to decolonize ongoing systems of oppression and indigenize treatment and programming. I have no conflicts of interest to declare today. So for the outline here, I'm going to be looking at literature on the gaps and barriers experienced by individuals in accessing all levels of evidence base, including harm reduction resources and treatment for their substance use disorders, both on the local level in so-called Vancouver and to the national level and extending globally. Harm reduction initiatives, including safer supply programs, are evidence-based approaches to mitigating harms associated with substance use. Harm reduction initiatives are often underfunded and overlooked, despite the huge role they play in improving people's quality of life and bridging individuals to healthcare and substance use treatment if that is something they're interested in. But most importantly, keeping people alive. Problematically, the voices of those with lived or living expertise through extensive community consultation and collaboration is often not centered in substance use disorder programmatic implementation process, despite the vast knowledge and expertise held by drug users themselves. If these voices are included in consultations, they are largely ignored in the actual planning of next steps due to an ongoing lack of political will, as we saw earlier this month in the new BC legislative report, the first report on the Select Standing Committee on Health about the toxic drug poisoning crisis. Due to ongoing colonial practices, Indigenous perspectives are especially left out of program planning, and so too are Indigenous knowledges and ways of healing, so therapeutic and central to many. This leads to even more heightened marginalization and overrepresentation of deaths and other negative outcomes like houselessness, child removal, missing and murdered Indigenous women, girls, two-spirit individuals, and others, and of course, poverty. While Indigenous-specific treatment programs do exist, like through the First Nations Health Authority, they often have long wait lists, are remotely located, and usually have other barriers to access them. For example, must be a status card holder, already connected to counseling or other community supports, etc. While it is also well known in the literature and across healthcare settings of the importance of retention in treatment programs and the positive outcomes therein, especially for individuals, but also for broader systems, there is less known about withdrawal management services specifically, including barriers in accessing them. Withdrawal management or drug detoxification centers, aka detox, is often viewed as an important entry point for recovery for individuals with substance use disorder, but it doesn't always function that way. So we will look at why that is the case. Worth noting is that detox is not treatment in and of itself. Like I said, it is, however, oftentimes a crucial first step in accessing treatment for people who use drugs and is used to physically detox from a substance under supervision, including managing withdrawal symptoms and other potential medical complications prior to beginning treatment. Treatment then is defined as social, psychosocial, and/or medical interventions to address the underlying causes of addiction, including trauma, mental illness, and sometimes complex behavioral issues associated with substance misuse. There is a spectrum of treatments available, including community-based or outpatient, counseling, facility or bed-based, aka inpatient, or pharmacological. When treatment is mentioned in this talk, I am primarily referring to bed-based treatment unless otherwise specified. Examples in this lecture are primarily Vancouver-centric, but examples from other locations will also be featured. So across the literature, we see very high no-show rates, consistently above 50%, both at the withdrawal management level as well as the treatment level. Vancouver Coastal Health is certainly no exception to this, as we see these figures mirrored at Van Detox, our local inpatient medically managed detox center, with over 50% of clients not making it to their initial intake appointment. This topic will begin to look at major barriers experienced by people who use drugs in accessing withdrawal management, as well as the continuum of treatment services, as there are many commonalities in the barriers across all these different services. Lastly, I'll be looking at implications for social work practice and how we can be a part of the solution moving forward, both at the micro and particularly at the macro level. So I did want to go over some pathways to service here. The continuum of services accessed is in a nonlinear and difficult to navigate decentralized network, both for service users and clinicians alike. So Access Central, this referral pathway is for withdrawal management, including all 4 levels of detox services and addiction recovery housing. While not all health authorities have all 4 levels of detox, Vancouver does. Level 1 is home detox for people with less acute detox needs and usually very stable housing. Level 2 is detox, which is intensive outpatient detox and is medically monitored withdrawal program intended again for more stable clients. Level 3 is medically monitored supportive detox like Harbor Light or on-site, but does not have 24-hour nursing staff. And level 4 is medically managed inpatient detox like Van Detox and is staffed with nurses 24 hours a day. Level 4 is intended for those with a history of complex withdrawals and/or acute medical needs, such as withdrawing from alcohol, GHB, or benzodiazepines. One barrier worth highlighting right off the top is the no smoking policy at Van Detox. I have heard anecdotally from many different sources, both clinicians and service users alike, that this presents as a huge barrier to detox, as people are already in a vulnerable and often highly uncomfortable state, are already become state when actively detoxing, but give up cigarettes at once. Ask that people give up as well can be too much to take on it. Many people won't pursue or they leave detox to this intake. Next is the Central Addiction Intake Team. So this referral pathway is used to access VCH contracted support transitional housing and recovery programs, such as Pacifica, Together We Can, New Dawn, etc. This is also where one applies for a stabilization bed while awaiting a treatment program, such as Rice Block. The client must call in 1 to 2 times per week to check in to keep their referral active or else risk losing their place on the wait list. Next, we have central access and discharge. This referral pathway is used for accessing tertiary mental health and substance use programs, such as Redfish and Heartwood. Wait times vary, but Redfish is up to an 8+ months wait to enter their regular program. Other referral pathways. So some treatment facilities are self-referral, for example, Turning Point, and many people are unaware of this. Additionally, various recovery houses, whether registered with assisted living or not, have other referral pathways as well, and historically often have little oversight. There are also a slew of non-health authority bed-based sites that accept income assistance, for example, Round Lake, and also private sites, which are extremely costly. This adds additional confusion and barriers to access various treatment facilities. It's important to know that along the continuum of care, many of these sites are not accessible and thereby create a physical barrier for many individuals as well. Worth noting is that there are major differences between health authorities in terms of accessing these services. We can see VCH is decentralized with numerous referral pathways compared to Fraser Health, which uses one centralized intake center for referral to all detox and treatment services along the continuum of care. A drawback to this approach is it can be gatekeepy and might limit the intake workers' capacity to see clinical nuances of individual cases. As you can see, there are many moving parts and the system isn't set up so it's as simple as send a fax application and an intake will happen. Individuals need someone to heavily case manage their applications, as there are often back and forths between referral source and intake staff through ongoing phone calls and emails. While there is one general referral application to whichever centralized intake stream, oftentimes the individual site will have other forms, including applications and agreements, required to be submitted directly to them. Additionally, many of these applications take hours to complete, and there is no simple way to see what application someone might already have submitted in the system by another care provider, leading to unnecessary and time-consuming repeated work that clogs up the system further. Sorry about that. So according to Withdrawal Management Services in Canada, the National Treatment Indicators Report published by the Canadian Centre on Substance Use and Addiction in 2019, it presents aggregate level descriptive information about those who access publicly funded community or hospital services for detox between 2015 and 2016. It was intended to be used to add to systemic level information necessary for policymakers to plan, create, monitor, and analyze services and supports for detox in Canada. The findings indicated that detox is most beneficial when followed by timely access to additional care, including pharmacological, psychosocial, and recovery supports. They found that most people don't receive specialized substance use treatment, and more detailed information and data are necessary to understand whether the appropriate supports along the continuum are both available to individuals and actually being used. It found that understanding people's gender, sexual orientation, cultural identity, mental and physical needs, age, goal of treatment outcome, and involvement of family need to be heavily examined to ensure effectiveness of detox. Key findings include that men use detox services more than women, and community-based services were more likely to be used by younger individuals aged 25 to 34, while hospital detox was used more primarily by middle-aged people aged 45 to 54. These key findings underscore the need for tailored treatment services that reflect unique needs of different people's identity as per best practice guidelines. This speaks to a theme that comes up throughout the literature, and that is that people who use drugs are not a monolith, and our services should reflect the vastly differing needs, goals, and identities of those accessing them. In a 2020 study published by the Harvard Review of Psychiatry, researchers looked at substance use disorders in the global mental health delivery context. Given the extensive biopsychosocial risks associated with substance use disorders, including increased morbidity and mortality, there have been significant improvements in evidence-based treatment options available in the last 2 decades alone. This includes an expansion of pharmacotherapies, as well as psychosocial interventions that can be tailored and delivered in a variety of formats. However, global data shows that the majority of people with substance use disorders still receive inadequate or no treatment at all, despite our deepened understanding of the health and social costs of untreated addictions. Additionally, the vast treatment gaps for those experiencing substance use disorders globally is the greatest of all mental health and medical disorders, illustrating that there are huge improvements to be made despite these expanded evidence-based treatment options and major medical advancements therein. The treatment gaps can be explained by many intersecting factors, including a lack of equitable and efficient access to mental health and primary health care, a lack of comprehensive and ongoing specialized addictions clinical skills amongst healthcare workers and other service providers, and an ongoing lack of political will at the policy level. Social workers are amongst those healthcare workers lacking clinical skills in the realm of addictions knowledge and treatment pathways broadly, and also tend not to be working at the policy level to help implement structural change. These facets are exacerbated by perpetual stigma, disenfranchisement, and marginalization of people who use substances. Siloed service delivery is a common issue faced by people who use drugs trying to access treatment, often resulting in increased wait times and other barriers to accessing services, contributing to heightened pre-treatment and program dropout rates. In one study from 2006, researchers looked at barriers to residential and outpatient treatment from the perspective of people who use drugs, with an emphasis on wait time, through a centralized intake unit in the Midwest United States. They found that up to 50% of individuals will experience pre-treatment dropout between their initial assessment and program entry date, with evidence showing that the longer the wait time is, the more likely individuals are to drop out. One participant found that the urgency she felt in trying to get access to drug treatment was at odds against the idleness of the wait list. Individuals waiting to access treatment are in a kind of limbo in which they cannot sign up for school or try to get a job or access improved housing or otherwise improve the material nature of their lives, often until they get into said treatment program and begin their recovery journeys. In order to avoid getting sick from withdrawal, individuals often find that they have to continue using while waiting. Another participant in this study speaks to compounding issues he experienced during long wait times, including poverty and housing insecurity, and found that since he already had nothing, he may as well get high and use while waiting. Participants waiting in preparation for getting treatment experience time differently than busy service providers. Beyond the actual barrier of wait times, the subjective experience of the passage of time makes waiting periods particularly difficult for those active in drug use and engaged with other risky activities associated with having to access the illicit drug supply. Many participants highlighted a sense of urgency to enter treatment as soon as possible as a way to counterbalance the otherwise emptiness of their day-to-day life. For others, the purpose of their sense of urgency was as an escape from a life or death situation. While healthcare providers may view a week of wait time as fair or even reasonable, participants may view the same week as feeling like forever or eternal, as one participant put it. Less research has been done on how time can be experienced as a symbolic process that gets reproduced in everyday settings and practices in a taken for granted way. Harm reduction and social work are ideologically aligned, centering client self-determination, meeting the person where they are at, and working collaboratively to advance autonomy and client-defined goals. Beyond wait time, other barriers to care include simply how we define treatment for people who use drugs and how we bridge or don't bridge them to other supports or addiction services if desired. While there are some community-based treatment programs that don't solely rely on abstinence as the marker for recovery, the majority tend to lean in this direction, as do governments. With abstinence as the marker for progress and success in these such programs, rooted in archaic, arbitrary, and highly paternalistic political agendas, harm reduction fails because these programs and systems fail harm reduction. The overemphasis on increasing treatment beds instead of or in addition to rolling out large-scale regulated drug supply is misdirected at best and functions as a way for politicians and policymakers to maintain prohibition and the status quo of the unregulated drug supply and mass deaths as a result. As we see in the following study, for many individuals, abstinence from drugs is not currently their goal for their substance use, but rather might include financial or physical stability, decreased stress, reducing or stopping the amount they inject, reducing their exposure to toxic drugs, and obviously avoiding death. As such, the ongoing overall focus on cessation of all drug use or total abstinence, again rooted in white and Christian value systems like the moral model, presents as a major barrier for many in accessing any support for their substance use. Through the eyes of 42 participants, this qualitative analysis looked at outcomes of the novel hydromorphone tablet distribution program serving roughly 70 individuals at the Molson Overdose Prevention Site, MOPS, in the downtown east side. Since this program opened in January 2019, it has again shown promising results for participants. A strength of this study is that they were able to have unstructured conversations with staff and participants, allowing for more organic information and insight to surface. Researchers also conducted over 100 hours of ethnographic observations in and around MOPS and used this additional rich data to really center the voices of the participants themselves. By expanding the logic of using pharmacotherapy to treat opioid use disorder, increasing safer supply through providing pharmaceutical-grade opioids and other drugs as a public health intervention, we can support people in their current and future treatment goals by providing alternatives to toxic street drugs. Major effective harm reduction initiatives in Canada and the United States, such as present-day overdose response measures, have predominantly been spurred by grassroots drug user organizations like the Vancouver Area Network of Drug Users, VANDU, the People's Harm Reduction Alliance of Seattle, and many others, and only later get sanctioned formally by provincial, state, or federal governments, if they get sanctioned at all. The recognition and expansion of these harm reduction initiatives highlight a vital step in bridging people to the continuum of treatment services, if desired, as well as, and most importantly, responding to unregulated drug poisonings. And yet there are limits in their ability to directly mitigate the risk of unregulated drug poisonings entirely by targeting the fentanyl-contaminated street drug supply. After all, dead people cannot access harm reduction initiatives, nor the continuum of substance use programs, and the reality is, so many people are dying while waiting to access these services. Through this distribution program, participants found other significant but unsurprising benefits from enrollment. One benefit was increased financial means, as they no longer had to spend excess time and money to access the illicit drug market to manage their withdrawal. These freed up finances led to other benefits, such as the ability to connect with children living out of province, improvements on their general health and wellness, like nutrition and sleep, and an overall reduced stress in their day-to-day lives. Moreover, this study builds on past research showing a reduction of risky behavior, like petty crime as a means of generating income, such as low-level drug selling, reselling goods, or property crime amongst people accessing safer supply. This is important when considering the role of safer supply in mitigating risks associated with the intersection of drug use and structural violence. And I'll get into more of this in the next slide. Through observation, it was found that MOP staff bridged clients to other medical appointments and services by scheduling and reminding people of these appointments and also arranging their transportation to and from. I will caution that safe supply initiatives embedded within the medical model tend to reproduce colonial harms, as many Indigenous, racialized, gender diverse, and other people do not feel safe within healthcare settings, let alone having intimate conversations with about their drug use with doctors and prescribers. As such, to see the full benefits of a public health impact through dispensing safe supply, a myriad of programs should be rolled out, accompanied by research and evaluation, with a variety of pharmaceutical-grade opioids and other drugs to choose from to meet the differing and evolving needs of people who use drugs. These could include the scaling up of medical models like the one at MOPS, compassion clubs like Van Du has done, where users buy pharmaceutical-grade opiates and other drugs, off-label hydromorphone or other opioid prescriptions, including those in existence already embedded within harm reduction services, automated dispensing machines or pharmacies, and storefronts. The larger the menu of accessible, safer options, the broader the positive public health impact will be for those most at risk of unregulated drug poisonings. What we don't need are more pilot projects, as the evidence is and has been there. As drug user activists say time and time again, save supply or we die. Certain barriers to accessing substance use services disproportionately impact some populations more than others. In the following open community-based cohort study from 2022, researchers wanted to understand the structural barriers as experienced by women sex workers in Vancouver over a 9-year period to help fill gaps in the literature, as this population remains significantly underrepresented in substance use research, despite the fact that there have been an alarming recent increase in fatal unregulated drug poisonings amongst women. Women sex workers who use drugs experience particular barriers and challenges due to the overlapping health and human rights inequities associated with the criminalization of both sex work and drug use. In Canada, Indigenous women face hugely disproportionate rates of gender-based violence, policing and criminalization, and drug-related harms, and have 8 times higher risk of overdose compared to non-Indigenous women. While the literature has already looked at how racialized policing impacts engagement with, while the literature has already looked at the ways federal drug policy reproduces colonial inequities amongst Indigenous peoples, less is known about how racialized policing impacts engagement with substance use treatment amongst Indigenous sex workers who use drugs. Among the 645 sex workers who used drugs in their study, 32.1% disclosed unsuccessful attempts to access substance use treatment during the study period, with Indigenous sex workers facing the highest likelihood of unsuccessful attempts. The participants' median age was 33, 51.3% identified as Indigenous, 47.6% identified as a minority gender or sexual orientation, and 62.6% had a prior mental health diagnosis. Colonial structures, both historic and contemporary, is why we see an overrepresentation of Indigenous women in street-based sex work, and has led to the disproportionate policing and criminalization of Indigenous women. For instance, Indigenous women only comprise 4% of the population, but disproportionately represent 33% of all incarcerated women. Researchers found that demographic factors closely associated with an increased likelihood of being unable to access substance use treatment include minority gender identity and/or sexual orientation, a recent history of opioid use, workplace or intimate partner violence, recent houselessness, and policing. They're finding that police harassment particularly was strongly associated with a 1.5 times higher likelihood of unsuccessful attempts to pursue substance use treatment is incongruence across the literature, demonstrating that high rates of criminalization endured by sex workers and women who use drugs pose significant barriers to general health care and other connected support services. Given these findings and evidence of system-level barriers to accessing services for stigmatized populations, including long wait lists, discrimination, and stigma, an expansion of low barrier and gender inclusive substance use treatment models and programs are desperately needed. Housing first approaches that offer stable housing and are connected with low barrier substance use treatment options tailored to meet the needs of Indigenous women are particularly important. In addition to a pressing need to introduce and expand low barrier, trauma-informed, and culturally safe substance use services for Indigenous women, this study calls for immediate policing reforms in conjunction with the dismantling of systemic racism against Indigenous women and femmes across and beyond all health and addiction supports and services. In the very important 2020 report, In Plain Sight, investigating anti-Indigenous racism in BC's healthcare system, it was found that more than 1 in 5 Indigenous respondents felt not at all safe when accessing mental health and substance use services, with many avoiding treatment as a result of past discriminatory and unsafe experiences. This is also evidenced by the fact that from 2015 to 2018, Indigenous patients are more than twice as likely as other patients to leave BC hospitals against medical advice. We see similar trends in no-show and dropout rates in the context of withdrawal management services, which will be discussed later. Discrimination, stereotyping, and racism in all settings are associated with higher rates of distress, suicide ideation, and substance use, and lowered health outcomes and well-being. This leads to a kind of feedback loop in which ongoing racism leads to increased likelihood of substance use, and then people are reluctant to access support for substance use treatment because of discrimination in the healthcare system, contributing to ongoing colonization. Many of the highlighted issues can be attributed to the lack of broader recognition and emphasis on the importance of utilizing Indigenous approaches to healing and wellness as a way of creating effective, inclusive, safe, and appropriate approaches to Indigenous health. Current efforts to improve access to ancestral medicine and healing are inconsistent and scattered across regions and providers, and are usually driven and held by select few individuals. Instead, these efforts and initiatives should be structural in nature and widespread, rather than treated as simply an afterthought or an add-on to existing services. And they should be led and informed by Indigenous peoples themselves. This report emphasized the necessity of implementing cohesive strategies for upholding the minimum standards in the UN Declaration regarding the inclusion of Indigenous health practices, bolstered by a solid recognition of the importance and strength of Indigenous ways of knowing and healing. From their report findings, one of the recommendations moving forward is that the BC government demonstrates tangible progress on their commitments to advance access to culturally safe and appropriate substance use services. While health disparities amongst Indigenous peoples is well known, or should be, the following research hopes to fill gaps in the literature by understanding unique experiences of Indigenous peoples in accessing detox and other mainstream substance use treatment services in what is colonially known as Vancouver, home to BC's largest urban Indigenous population. This is most visible in the downtown east side, which has a disproportionate representation of Indigenous peoples. At least 1/3 of the city's total Indigenous population reside in or near the downtown east side, despite representing less than 2.5% of the city's population. You just have to have other models. Our DNA is different is a qualitative research study conducted by researchers from the BC Centre on Substance Use and the Western Aboriginal Harm Reduction Society. They conducted their research through Vandu and employed an Indigenous-led, community-based approach to research by using Indigenous methodologies like talking circles to explore experiences in accessing withdrawal management and substance use services. To begin to understand different Indigenous perspectives in accessing detox and mainstream treatment is to investigate intersecting forms of oppression shaping those experiences. 3 key themes emerged from the talking circles used in this research project, including 1, barriers in accessing withdrawal management and other treatment for substance use disorder, including extensive wait times and a lack of follow-up support post-treatment. 2, inaccessible and inappropriate structures and policies in both withdrawal management and mainstream treatment programs, including forced Christianity in some settings. And 3, the importance of culturally competent and trauma-informed, peer-led treatment programming. While the vast benefits of Indigenous-centered, trauma-informed, and culturally safe programs and practices for Indigenous peoples who use drugs has been highlighted, harm reduction services and programs as legitimate treatment or a gateway to treatment for people who use drugs are often dismissed. Yet, as we saw in a previous study conducted at MOPS, looking at the myriad of health and social benefits of harm reduction and safe supply initiatives, these continue to remain on the margins, and very few people are able to participate or benefit from them. Harm reduction services, in conjunction with culturally safe, peer-driven supports, can increase Indigenous people's access to improved health outcomes and an increased quality of life. I wanted to also include this quote from one of the participants to capture the experience in their words. What I've noticed about Vancouver is it's difficult to get into treatment. Don't want to seem controversial, but seems like there's always a free meal, free shelter, clothing, bus tickets. It seems enabling. They make it hard to get into treatment. I wanted to be clean for 6 months, and it's an impossibility. Not a lot of research has been conducted to look into why the no-show and dropout rates are so high amongst Indigenous and non-Indigenous populations admitted to medical withdrawal management services in Vancouver. The following study, published in 2013, focused on factors associated with high dropout rates at Vancouver Detox. At the time, the no-show rate for Indigenous clients was 41%, and for non-Indigenous clients was 32.7%. The service dropout rates were 25.9% and 20% respectively. This is significant as Indigenous peoples comprise 20% of the client sample at Vancouver Detox, despite being only 5% of the total BC population. They found that having no fixed address was the primary factor driving dropout within this population group, which disproportionately impacts Indigenous peoples due to ongoing social exclusion. They found that this was a major barrier because Access Central relies on communicating via phone call back to clients when a bed becomes available. And there's a strong link between being NFA and not regularly having access to a reliable phone. Thus, the onus then becomes on the individual to stay on top of communicating back to Access Central. In their study, 84% of NFA clients who experienced pre-detox dropout was due to loss to contact, indicating that the method was a significant barrier for this demographic to start their detox and treatment journeys. This finding adds to the mountain of evidence that providing Indigenous and other NFA clients with stable housing will facilitate greater ease not only for treatment staff to reach them once a space becomes available, but to improve the quality of lives and support their long-term recovery goals. This could both substantially improve treatment initiation and decrease no-show rates for both population groups, as well as increase supports post-treatment, which was identified by Indigenous participants in the previous study as a prominent barrier in accessing withdrawal management and treatment services along the continuum. For non-Indigenous clients, they found that being male, without children, again NFA status, and being on methadone at time of referral were factors highly associated with an increased pre-detox dropout. This study highlighted that the longer the wait between the initial phone call with expressed interest and the scheduled intake date, there's an increased likelihood of no-show, as we saw was the case from the study from the Midwest, the study conducted at Bandu, and so many others. For clients on methadone at the time of referral, they might experience a longer wait time than others because of the time it takes staff to coordinate the date and time of their last dose and to maintain the continuity of methadone treatment in detox. Additionally, for non-Indigenous clients, this study found that younger clients were more likely to drop out of detox, as well as those with opioids as their primary drug of choice, and reflects similarities to findings from other studies. Thus, these results emphasize the importance of social factors like a lack of culturally safe and accessible services and being unhoused for Indigenous clients in comparison to more substance-specific factors, example, drug of choice, and age for non-Indigenous clients. This also highlights another barrier in the system that's worth noting, the lack of youth-specific addictions resources available. In terms of limitations of this study, it did not include an investigation into psychiatric diagnoses, which past literature has shown is closely associated with increased no-show and dropout rates. We can begin to focus on specific barriers to accessing outpatient and residential treatment as people transition out of detox services and look to go into treatment services. So inpatient detox centers are historically used for managing symptoms from acute withdrawal through medical stabilization, as I noted, but are becoming places of social support for clients as well, blending the medical and social models of detox. The goal is fundamentally different from substance use treatments, which incorporates pharmacological and psychosocial interventions and healing methods to help clients advance and sustain their recovery goals. However, the vast majority of clients do not receive further substance use treatment post-detox, illustrating the dire need for withdrawal management services to bridge this gap from detox to treatment if desired. In this 2022 qualitative study using semi-structured interviews, 24 patients in the largest detox center in Boston were interviewed to uncover some of the barriers in accessing substance use treatment, both inpatient and outpatient, post-detox admission, and to glean possible solutions from their experiential knowledge to help mitigate these gaps. Given the literature shows that many people return to detox centers on multiple occasions, researchers in this study thought that interviewing patients on admission to detox could provide vital information about past experiences after leaving the same or similar facilities. These past experiences, whether positive and/or negative, are often critical elements in the likelihood of their ability to initiate and sustain further treatments. The lack of continuity of care connecting to outpatient treatment and limited physical capacity of detox centers and inpatient treatment centers were the most commonly communicated barriers to ongoing care for individuals. Researchers also identified possible solutions to these gaps as informed by the patients themselves. The importance of having a menu of options for substance use treatment, and by extension, having increased access to low barrier treatment options specifically, were most commonly identified solutions amongst the participants. I'll look at some other identified solutions in the next slide. As we saw was previously associated with high no-show rates in accessing detox services, the lack of continuity of care is a barrier that is also mirrored in the transition from inpatient detox to ongoing substance use treatment, including both inpatient and outpatient treatment. Many participants described feeling that detox was not actually functioning as an entry point in their recovery process, as there lacked an explicit plan for their care continuity, including a lack of follow-ups from care providers. This care planning left many finding themselves being readmitted to inpatient detox multiple times. Many noted that detox centers do not have adequate staffing numbers like case managers, who are primarily the ones assisting patients with their care planning. Additionally, given the short amount of time, a week or less, at inpatient detox, participants felt that this was not long enough to sustain their recovery post-discharge, especially given that many struggled to find somewhere else safe to go to continue recovery upon discharge. Many participants highlighted system-level barriers to accessing ongoing care for their opioid use disorder, including the physical capacity and limited number of available beds at treatment centers, and was cited as an especially common barrier for unhoused or unstably housed participants. Participants noted that they face additional triggers and challenges for their opioid use when they get discharged back to the streets or to a homeless shelter. They noted that safe and secure housing was a critical factor for sustainable recovery and emphasized using treatment as a way to get support with their housing insecurity. Others noted that discharging from detox without a solid plan in place left them without needed supports to work toward important next steps needed for success on the road to long-term recovery. Some noted the difficulty they faced in navigating the system to find a clinic or get an appointment without phones. I think this quote from one of the participants sums it up really well. I remember when I called here after I left one time. I called to get help, like on a day program or a Suboxone program, any type of help. And the lady upstairs told me, like, once you leave here, we're not responsible for you guys. In terms of solutions, due to the chronic relapsing nature of substance use disorders, with many participants reporting numerous different treatment attempts during their recovery journey, they identified the need to have different options for treatment to optimally serve their current needs, especially low barrier options and access to OAT. As individuals and their relationship with their substance use evolves, their options for a treatment path should reflect this, including the ability to initiate treatment at the time of discharge, should they choose this. Additionally, bolstering case managers at inpatient detox centers would help patients navigate and bridge the gap between detox and ongoing treatment, and would improve the staff's ability to tailor care to meet individual needs. Case managers could also improve outcomes by scheduling short follow-ups for patients post-discharge, and would help move away from once you leave, we're not responsible for you guys type sentiments as seen in the quote on the last slide. Also, and importantly, addressing housing instability, not just at the individual level, but through real efforts to address the ever-growing housing crisis, needs to be at the forefront when looking at solutions to reduce barriers in accessing both detox and treatment services, and was underscored by many of the study's participants and heavily emphasized throughout the literature, as you've heard. Ongoing studies should investigate other possible solutions to improve ease and access to treatment after inpatient detox. In terms of limitations of this study, there's a few worth noting. The study took place at only one detox center, thus limiting the generalizability of the findings. Beyond this, most of the participants included in the study were English-speaking white males, further limiting the generalizability of the findings both to non-English speaking individuals, as well as racialized populations, women, and gender diverse individuals. Now that brings me to implications for social work practice. In terms of applications to social work practice, there are many. At the micro level, social workers have a lot of rich values and skills in supporting individuals in their treatment and recovery journeys, however they envision these for themselves. Social workers play an important role in the delivery of counseling-based substance use treatment options, both facility-based and community-based programs. Additionally, by broadening who the client is through the inclusion of family systems, social workers can offer family counseling as well, as there's lots of evidence to suggest that supporting families improves treatment outcomes for the individual. Social workers also have a role to play in the screening of substance use disorders, and is something that remains at the margins of mainstream clinical practice. While we are also uniquely positioned to be able to reduce gaps in service delivery and to provide more continuity of care in terms of individualizing treatment and recovery care planning, and to practically arranging for services and supports like transportation to and from withdrawal management or treatment sites, following up with people, either if they miss an appointment or after discharge, as well as advocating, whether that's to intake staff at a given treatment site or for better housing, or to doctors, nurses, and other social workers providing direct care to clients when we see something that is either not evidence-based or is otherwise problematic on behalf of our clients. Since a lot of us have very high caseloads and find it difficult to fully support those we work with, it's important that we take on higher level positions as well, to better inform the real needs of other social workers and adjacent working professionals, and of course, the populations we serve. This brings me to my next point on macro level applications for social work practice. I would encourage social workers to take on more leadership roles to be able to better inform drug policy, research, and programmatic planning and implementation, including paying those with lived or living expertise a living wage. There is a lack of literature on social work's roles in how we contribute to sustaining barriers in accessing addiction services across the spectrum. There are lots of other areas social workers could take part in developing further research in, including our role in advancing drug policy, as seen in a newly published article entitled Social Workers as Potential Agents for Drug Policy Reform. We can also take on roles in advocating for service mandate changes to reduce barriers in accessing detox and treatment services, while moving away from abstinence-based programming toward embracing harm reduction, including safe supply. If we see a new program getting rolled out that doesn't include, center, and is indeed led by people who use drugs themselves, including and especially Indigenous peoples, we can use our commitment to social justice, anti-racism, and advocacy to create more equitable systems and services to ensure that the right voices are at the table and that they are actually being heard, even and especially when that means quieting our own. This is a way for social workers to remain steadfast in our commitment to undoing our colonial legacy in our practice and not just on paper in our code of ethics, by creating more just systems for those they are intended to serve, including those most impacted by social, economic, and racial injustices and policies. Since many social workers are uniquely positioned with having the ability to see and understand systemic issues, as well as valuable frontline experience and close proximity to drug user activists, we occupy a flexible space in being able to make research, programs, and policies more reflective of real-life needs through the support of those already living and doing this work on the ground. Indeed, it is not enough to denounce stigma and discrimination when we are actively contributing to it. Thank you. That concludes my presentation. I just wanted to include some resources here, including Crackdown Podcast, the National Harm Reduction Coalition, and some local drug user activist organizations. And here's my references. And I just wanted to open up to any questions if anyone has any. Thank you.
Thank you so much, Kara, for that presentation. There are a few questions that are coming in, so maybe just for the sake of time, I'll just jump right to them. I'm having trouble viewing them. Just give me 1 second. Sorry, Amir, is there a way that I can view the questions? They were up and then now they're gone. Okay, perfect. Okay, so the first question is, did you find anything about people using bed-based treatment resources as a social detox, especially for people experiencing homelessness, not as a perfect match for treatment, but it provides a short-term safe place where they can meet their needs and have safe relationships with healthcare providers? That's the first question.
If that's in the context of treatment services, like bed-based treatment services, I haven't come across that literature during my review, but I did highlight that detox is increasingly used for those reasons as well. And I've also heard that, like in practice, that that's something people are pursuing.
Mm-hmm. Sorry, I'm just trying to get the second question sent as well. Great, and this one, given the heavy investment in biomedical approaches to substance use by the government, how can we adopt a more holistic approach instead of being agents of the state?
Yeah, it's a pretty big one. I think like
summary of the presentation question.
Asking the right questions and kind of challenging taken for granted maybe assumptions we see in a medical model is somewhere to start. And then I think for social workers and other professions as well, like really organizing and like making efforts to advocate on more of a structural level, I think is really, really important at this time when we're so many years into this crisis.
Mm-hmm. Absolutely, I would agree with that completely. Maybe we've got one more question if you're okay with that.
Sure.
Are you aware of any non-abstinent based or harm reduction stabilization programs or research?
No, I'm not aware. I'm sure that does exist, but if you find out, please let me know.
I'm also not aware of any in the Vancouver area, at least, but I haven't done as much research on this topic as you have. Well, with that, I thank you so much for all of the hard work that you've done to create this presentation. Really appreciate it. And I would encourage anybody else who has questions to reach out directly to Cara.
Yes, absolutely. Thank you everyone for attending today. I appreciate it.
I'm not sure if it's still going.